This conference will now be recorded.
Hello, dear doctors. Good to see you here. So today we are going to talk about diagnosis and management of ectopic pregnancy. This is Greentop guideline number 21, and it is one of the most important guidelines. Why? Because we are going to deal with so many cases of ectopic pregnancy or suspected ectopic pregnancy in your clinical practice, and also for the sake of exam, you should be conversant. You should know that what exactly is an ectopic pregnancy, how many different types of ectopic pregnancy can be out there, and if you don't have any idea, then you cannot diagnose it. So what you can think, the eye can see that. Very important topic. Okay, and you are going to get several questions here in your exam. They are asking questions of both types, I mean the single best answers as well as the extended matching questions. And sometimes the information is presented in a complex way, and you can answer the questions only if you have a good grasp on the subject. Okay, so each line of this guideline is very important. So first of all, you should know what is an ectopic pregnancy. So an ectopic pregnancy is any pregnancy implanted outside of the endometrial cavity. Okay, it is located outside outside of the endometrial cavity. The incidence has been stable for a long time, and the incidence is 11 in 1,000 pregnancies. So on average, in 1 year in UK, 11,000 ectopic pregnancies are diagnosed, and this incidence makes up like 2 to 3% of the pregnancies, which 2 to 3% of the total pregnancies which attend the early pregnancy care units, and they end up having a diagnosis of ectopic pregnancy. So it has many short-term effects, like it can cause some acute bleeding problem, pain, and then it has long or late consequences in the form of tubal damage, relative infertility, and more importantly, the risk of having another ectopic pregnancy. So this is potentially a lethal problem, fatal problem. The mother can die without any symptoms, or she may die due to extensive hemorrhage in case the tube ruptures, fallopian tube, it ruptures. Then the question is that how is a tubal pregnancy diagnosed? So first of all, you are going to take the history of the patient. If this is an acute case, then don't forget the ABCD, ABCDE, everything you should be doing here. And then you should attend and then first revise your patient. And if she is like the vital signs are too much disturbed, then you need to just take consent. You need to rush this patient to the OR. So during the exam, you will have to use your common sense and the practice and the guideline recommendations to make a decision for the management of the patient. So how do we diagnose it? You have taken the history, patient is stable. So there is ultrasound to help us. Which type of ultrasound you are going to do? So first we have to diagnose the transvaginal ultrasound, because this is usually a complication of the very early pregnancy. So this is the diagnostic tool of choice for tubal ectopic pregnancy. Tubal ectopic pregnancies, they should be positively identified, if possible, by visualizing an adnexal mass that moves separate to the ovary. So if you will touch the cervix with the probe, you can see that it is moving away or it is moving independent of the ovary. So a skilled person should be doing it. And so you should seek help if in case you cannot diagnose yourself. So sometimes, so this is the most common find. Okay? So it is a very sensitive test. TVS, it has a sensitivity of 87 to 99% and specificity of 94 to 99%. And these questions have been asked in the exam in the form of SPA. So pay attention to these numbers. And the false negative the laparoscopy's rate is 3 to 4.5%. This is when you suspected that the patient is having some problem, but then we opened and we found that there is no ectopic pregnancy. So laparoscopy is no longer the gold standard for diagnosis. If they ask you which is the modality of choice, which is the diagnostic test of choice, your answer is TBS. Okay, don't think that lab we have to do for the diagnosis. Okay, it is no more recommended as the first line thing. So what do we see on the ultrasound? In almost 50 to 60% patients, you are going to see inhomogeneous or non-cystic adnexal mass. That is the most common finding. And you should remember that an empty extrauterine gestational sac will be present in around 20 to 40% of the cases. Another question, which is the first structure that you ever see on the TVS in a normal pregnancy or abnormal pregnancy? Your answer is yolk sac. When can we see that? We can see it at 4 completed weeks of pregnancy. So, and then in the very early gestations, you can see a sac and there can be embryonic pole with or without any cardiac activity, and this you can see in almost 15 to 20% of cases. All of these numbers are very important, very helpful in answering the single best answer questions. Sometimes you will see that the endometrial cavity is very thick and the lining is very thick, and sometimes there will be just fluid collection like that. Okay, so in 20% cases you are going to see thickening, and then you are going to see the fluid collection, and it will give you the appearance of a sac, but it will not be a sac. So that's why we call it a pseudo sac. So the intradecidual and the double decidual signs, they can be used to diagnose an early intrauterine pregnancy. And the intradecidual sign, it can be described as a fluid collection with an echogenic rim located within a markedly thickened decidua on one side of the uterine cavity. So you should know that what is a genuine gestational sac and which one is a pseudo sac. So the double decidual sign, like I've described, it is described as an intrauterine fluid collection surrounded by 2 concentric echogenic rings. So in practice, it can be very difficult to distinguish a pseudo sac which has like collection of fluid like that. Because that's why you should try to look for the other things also, like you should look for the mass, you should look for the free fluid on ultrasound. The free fluid actually is not a diagnostic sign, but it will point towards a diagnosis of an ectopic pregnancy. You should remember that a little amount of the fluid is normal because all structures, they are going to move over, glide over each other. So if there is no fluid, there is no lubrication, then there is chance of injury friction between on the visceral outer surfaces. So that's why you have to mind that very well. So this classic finding of having echogenic fluid, it is present in about 28 to 56% of the ectopic pregnancies. Here the significance is that if you see the fluid, you should think about a ruptured ectopic pregnancy. Okay, so and most commonly it is due to blood leaking from the fimbrial end of the tube, of the fallopian tube. Then biochemical investigations, they can be very helpful. So which investigations we can do? Of course, we need to test the serum beta human chorionic gonadotropin level. It is very useful for the diagnosis, and it is furthermore, it is very important. You should know the level of the fluid because it is going to dictate that which treatment modality you are going to use. A serum progesterone level is not useful in predicting ectopic pregnancy. So never choose that as an answer. It's going to be a wrong answer in almost all of the situations. So people think that if we have done like one single beta HCG level and it is less than 1,000 international units, it means an ectopic pregnancy is unlikely. This is a false assumption. Take the things as they occur and follow them like the standard algorithm and the guideline dictates. Okay, so don't think that if the at the initial presentation the level is very low, so it doesn't exclude ectopic at all. Cases of ruptured ectopic pregnancy, they have been reported at levels as low as 20 international units, so you have to be very careful. So you are going to combine both TVS and serum beta HCG. Then we should remember that how many different types of ectopic pregnancies are there. There can be a tubal ectopic pregnancy, there can be a cervical ectopic pregnancy, there can be an ovarian pregnancy, ectopic pregnancy, there can be an abdominal ectopic pregnancy, there can be cesarean scar pregnancy. So many types are there. And remember, there are very subtle differences in diagnosing between the different types of ectopic pregnancy. So you have to be very careful. So how is a cervical pregnancy diagnosed? So each diagnosis has specific ultrasound criteria. So for diagnosing a cervical ectopic pregnancy, we should be able to see an empty uterus, a barrel-shaped cervix, a gestational sac which is present below the level of the internal cervical os. Below the level of the internal cervical os. The absence of the sliding sign and blood flow around the gestational sac when you are using colored Doppler. So the cervical pregnancies, they are rare. What is the incidence? They make up like 1% of all ectopic gestations. So the criteria I'll repeat for you: empty uterine cavity, barrel-shaped cervix, gestational sac present below the level of the internal os, absence of the sliding sign and blood flow around the gestational sac when you will use colored Doppler. So the sliding sign, it is helpful in differentiating an ectopic pregnancy from the miscarriage. So what exactly is this phenomenon? When the pressure is applied to the cervix using the probe, in a miscarriage, the gestational sac, it slides against the endocervical canal. But it doesn't move in cases of an implanted cervical pregnancy. Why? Because the structure is fixed, so it will not move at all. So when are you going to do the serum beta HCG? A single serum beta HCG should be carried out at the time of diagnosis. So in case at the initial presentation, the level of the serum beta HCG is greater than 10,000, it will decrease the chances of successful methotrexate treatment. Actually, in the literature, if you will go to the ACOG guidelines, the methotrexate has been administered even at levels of 12,000, but then you will be giving multiple doses, so it will not be cost effective. So you have to make the things cost effective also. That is one issue. Okay, so the next type of pregnancy we are going to talk about is a cesarean scar pregnancy. So we should know that the ultrasound is the primary diagnostic modality, and better to use the TVS. And if the things are not clear, you should have both views: view from above, which you can do with the help of the transabdominal ultrasound, and then below, because if you can't see anything clearly on the abdominal, then of course you have to do the TVS. If you have to choose between two, then you should choose the TVS, because in the TVS you can see things even when the beta HCG is 1500, and for the abdominal the serum beta HCG should be at least 3000. So you should do this and start with the TVS, and if required, you're not sure, you want to look at the fluid, and then you can do that transabdominal also. So what is the role of MRI? MRI can be used because it is a good thing, good technique to visualize the soft tissue. But this is a second line investigation. If the diagnosis is equivocal, like you have done the ultrasound, you couldn't make a final diagnosis. So this is the time to go for the MRI. So what is the incidence of the Cesarean scar pregnancy? Any one of you? Yeah, you can write in the chat box. Yes, I will agree with you. The incidence of the Cesarean scar pregnancy is 1 in 2000. That is one thing. So just like the cervical pregnancy, cervical ectopic pregnancy, Cesarean scar pregnancy also has a ultrasound diagnostic criteria. There should be empty uterine cavity. There should be a gestational sac or solid mass of the trophoblast located anteriorly at the level of the internal os, embedded at the site of the previous lower uterine segment Caesarean section scar. Thin or absent layer of myometrium between the gestational sac and the bladder. There should be evidence of prominent trophoblastic placental circulation on Doppler examination. And finally, there should be empty endocervical canal. So 13% cases of Caesarean scar pregnancies, they are usually misdiagnosed. They were misdiagnosed as intrauterine pregnancy because you have to be vigilant when you are doing ultrasound. Take time to do the things and look at all the structures carefully. Okay, because this can be mixed because it is surrounded by a very thin tissue of the this biometric tissue, so it can be missed. Okay, it can happen. So you can do the Doppler, and you should pay attention when you are looking at the patient, like doing the ultrasounds. And if you are not able to reach the diagnosis, then you will have the option to go for MRI. So remember that MRI features of the Caesarean scar pregnancy are the same as we described for the ultrasound criteria for the diagnosis of Caesarean scar pregnancy. So then again, should we do any biochemical investigations? So dear doctors, no biochemical investigations are needed routinely. Okay. So a serum beta HCG level, it may be useful as a baseline prior to monitoring if conservative treatment is contemplated, but it doesn't have a role in the diagnosis of Caesarean scar pregnancy. Important to remember because they are asking these questions in the single best answers. Okay, the next type of pregnancy, how is an interstitial pregnancy diagnosed? You know that the fallopian tube has 4 parts, so the ectopic pregnancy can occur in any part of the tube. That's why we are taking the different names and these are the sub-classifications of the tubal pregnancy, subtypes of the tubal pregnancies. So the interstitial pregnancy, what is the ultrasound criteria? So the ultrasound criteria for the diagnosis of interstitial pregnancy are empty uterine cavity, products of conception or the gestational sac which are located laterally in the interstitial or the intramural part of the tube and surrounded by less than 5 millimeter of myometrium in all imaging planes and presence of the interstitial line sign. Sonographic findings in 2 dimensions, they can be further confirmed if you would use 3D ultrasound if you have it on your unit to avoid misdiagnosis with early intrauterine or angular. Angular means that the pregnancy is implanted in the lateral angles of the uterine cavity. So we can differentiate it from the angular pregnancy. So MRI, it can be also be helpful in the diagnosis of the interstitial pregnancy, but the diagnostic modality of choice is again TVS. So just remember its incidence varies between 1 to 6.3% of ectopic pregnancies. Remember that the interstitial part of the fallopian tube is about 1 to 2 centimeter in length, and it traverses the muscular myometrium of the uterine wall, and it opens via the tubal ostium into the uterine cavity. Here again, a lot of experience is required because we can miss it. Okay, we can think that maybe it is the normal pregnancy, but it is located in the angle between the tube and the uterine cavity. So if you do MRI like you did the TVS, you didn't reach any diagnosis, then what should be done? Then you can go for MRI. Now you should be asking me that what is an interstitial sign? So basically the interstitial line sign, this is a thin echogenic line extending from the central uterine cavity echo to the periphery of the interstitial sac. And the interstitial line sign, why we talk about it? Because it has a sensitivity of 80% and specificity of 98% for the diagnosis of interstitial ectopic pregnancy. On MRI, you can see a gestational sac-like structure, which will be placed lateral to the cornu, surrounded by the myometrium. That is one. Okay. So then the presence of intact junction zone, that is the endomyometrial junction between the uterine cavity and the gestational sac-like structure, they also support the diagnosis. So do we need to do serum beta HCG for the diagnosis of interstitial pregnancy? So a single serum beta HCG, it should be carried out at diagnosis to help with management. In some cases, you can repeat the test, serum beta HCG, after 48 hours. It will be helpful in deciding the further management. So ideally, if you get you have 3 reports, three results of serum beta HCG, they are the best thing. They're very helpful. Otherwise, at least 2 reports should be there. Okay, the next type of pregnancy is Cornual pregnancy. How do we diagnose it? Again, TVS. So what is the criteria? The criteria for diagnosis of the Cornual ectopic pregnancy on ultrasound is visualization of a single interstitial portion of fallopian tube in the main uterine body. Now it is more towards the center, more medially placed as compared to the interstitial pregnancy. You can see, you can visualize a gestational sac or the products of conception which are seen mobile and separate from the uterus and completely surrounded by myometrium and a vascular pedicle adjoining the gestational sac to the unique garment uterus. That is very helpful for the diagnosis of Cornual pregnancy. So the reported incidence of Cornual pregnancy is 1 in 76,000. So this is one of the rarest type of the ectopic pregnancy. But we are scared of this type of pregnancy. Why? Because this pregnancy can very advanced to like 8 weeks, 10 weeks, and your patient can bleed like hell, and it can be a life-threatening condition. So again, we can do a single serum beta HCG at the diagnosis, and then we can repeat it after 48 hours to make the management plan. The next type of pregnancy is ovarian pregnancy. How do we diagnose it? So there are no specific agreed criteria for the ultrasound diagnosis of ovarian ectopic pregnancy. So, but there can be some findings which are suggestive of the ovarian ectopic pregnancy, like the uterus may be empty, and then it can have a wide echogenic ring with an internal anechoic area on the ovary. So there would be like whitish ring outside, and it will contain a blackish shadow where the fluid is collected like that. Okay, so it will give the impression of a pseudo sac. So this type of pregnancy is also very rare, and the challenge here is, the ovaries, they produce the ova, and now there can be a luteal cyst. So it's very hard to distinguish an ectopic pregnancy from corpus luteal cyst. That is one thing, okay? Or it may be a tubal ectopic pregnancy, which is just stuck adherent to the ovarian, to the ovary, or maybe there can be like you will see the ectopic and you will see a second corpus luteum. There can be ovarian germ cell tumors, and there can be other ovarian pathologies. So in such cases, the diagnosis is usually confirmed surgically, and histopathology is going to help us there. Again, just like other types of ectopic pregnancies, you have to do the baseline serum beta IgG, and then you will repeat it at 48 hours, because it is going to help us in making the management plan. All right, the next type of pregnancy is an abdominal pregnancy. So we can use the ultrasound criteria to diagnose abdominal pregnancy, and the ultrasound diagnosis are, and the criteria are absence of an intrauterine gestational sac, then absence of both an evident dilated tube and visualization of a complex adnexal mass. Then thirdly, you can see a gestational cavity surrounded by loops of bowel and separated from them by peritoneum. Fourthly, you can see a wild mobility similar to fluctuation of the sac, and this will be particularly evident with the pressure of the transvaginal probe towards the posterior cul-de-sac or the pouch of Douglas. You will see that this area, there is a sac and it is mobile, it is fluctuant, especially in the posterior direction, because there you can find it can find some space to expand. Okay, these are the things. So, and these pregnancies are also very risky. Again, the incidence can be like 1 to 6%, and sometimes it can be an intrauterine pregnancy which has moved up into the abdominal cavity through some gap, some space into the uterine wall. Maybe this area was weak, maybe there was some perforation, so many things can be there. Infection was there. And the bad thing is that such pregnancies, they can go very well, and they can go beyond the first trimester. So again, you should have, we need to do any biochemical investigations here? So actually you should have a high index of suspicion on the basis of high beta IgG in combination with the ultrasound findings. So basically, we can say that for the diagnosis of an ectopic pregnancy, you have to pay attention to the clinical condition of the patient, which you are taking from the history and then how she is presenting. Then transvaginal ultrasound, and the third thing is serum beta IgG. Okay, so what is a heterotopic pregnancy? It means there is a pregnancy in the uterus, inside uterus, normally located uterus, intrauterine pregnancy, and extrauterine pregnancy. The incidence is very low. Like most of the books, they have given a figure of 1 in 35,000. But if we miss one, then it can be disastrous. And then for the treatment, you have to go for surgery, because obviously we cannot give methotrexate if there is one normal and one abnormally located pregnancy. So it should be heterotopic pregnancy. It should be considered in all women presenting after, yes, after assisted reproductive technologies. So then also in women with an intrauterine pregnancy who are complaining of persistent pelvic pain, and also in those with a persistently raised beta IgG level following miscarriage or termination of pregnancy. Always think about heterotopic pregnancy if your patient is having multiple complaints or she had this assisted IVF pregnancy. Then if she has experienced a miscarriage, but still she is experiencing pain. So in such cases, you have to think about heterotopic pregnancies. So as you can make up that the serum beta HCG level is of limited value in diagnosing heterotopic pregnancy, because we don't know that this is coming from the normally located pregnancy or coming from the abnormally located pregnancy. So then you should remember that what are the management options. Management is the key thing. First challenge is diagnosis. And then after diagnosis, you need to make proper management options. Select the most suitable type of treatment therapy. So what treatment modalities do we have with us? Treatment of the ectopic pregnancy can be divided into surgical, pharmacological, or conservative treatment options. These options are most suitable for tubal pregnancy. So if your patient is stable, then you can go for laparoscopic surgical approach. That is going to be much better, and it is preferable to an open approach due to its associated benefits. Then if there is a healthy contralateral tube, then you should go for self-injectment. If the patient has a healthy contralateral, the tube which doesn't contain the pregnancy, that is healthy, in that case, the tube which is containing the ectopic pregnancy, you can resect it. Okay, so self-injectomy is preferred over self-ingostomy. Why? Because in women with a history of fertility reducing factors, like she had a previous ectopic pregnancy, she has contralateral damage tube, she had previous abdominal surgery, she has a history of pelvic inflammatory disease, self-ingotomy should be considered. Why? Because she has like many factors which compromise her fertility outcomes like that. If she has healthy tube, just go for self-injection. Okay. But if she has some issues, then you have to think about all other factors, because she has a history of fertility reducing factors. Self-ingostomy should be considered. In case your consultant, of course, this is going to be the decision of your consultant, but you should know that how you are making this decision, because it seems sometimes it seems like illogical one. So if a self-ingotomy is performed, the woman should be counseled that she can have different risks. What are these risks? Of course, there can be persistent trophoblast, which will need serial estimation of serum beta HCG, and we have to follow up by weekly serum beta HCG levels. We also need to tell them that if the levels they become stuck, they plateau, or they start rising, then they will have to undergo a further management. What further management can be provided in such cases? You will have to administer systemic methotrexate, or you will have to do self-injectomy. So whenever you are prescribing any medicine, you have to tell the patient about the side effects, and the RCOG then have to ask you about the side effects of the treatment. Remember that 70% of the patients are going to experience abdominal pain, because it is going to cause inflammation of the linings. Okay, so the patient is going to experience pain. So tell them, counsel them, tell them that if they experience any abnormalities, any pain, persistent pain, severe pain, or they have some other symptoms, they should come to the hospital. So systemic methotrexate, it may be offered to suitable women with a tubal ectopic pregnancy. Okay. So, and it should not be given at the first visit. Don't administer this methotrexate at the first visit unless the diagnosis of ectopic pregnancy is absolutely clear and a viable intrauterine pregnancy has been excluded. And so you have to be very careful here, because it can lead to medical legal issues. Expectant management is an option for clinically stable women with an ultrasound diagnosis of ectopic pregnancy and a decreasing beta-HCG level. Initially, it should be less than 1500 international units. So this is so when you will think about the surgical management. So the point here is that the majority of the tubal ectopic pregnancies, they are managed surgically. Laparoscopy is preferable to laparotomy due to its many advantages, such as your patient will be staying in the hospital for a shorter time, it will have a shorter operation time, less intraoperative blood loss, and lower cost and lower requirement for the analgesia, and less chance of adhesion formation. So all of these are helpful in the short term and also in the long term. That is one thing. And the evidence suggests that you choose laparoscopy or laparotomy, they will have no effect. They will have no difference in their effect in the subsequent successful pregnancy. That is one thing. Okay. So, but obviously, in cases where we want to conserve the tube because of on account of different factors, then the chances of subsequent there is risk that the patient will have a repeat ectopic pregnancy. And higher rates of subsequent intrauterine pregnancies, they have been found if salpingotomy is preferred rather than salpingectomy in women with a history of fertility reducing factors. That's why you have to think about salpingotomy in the women who had some bad factors in the history. What were those bad factors? Previous ectopic, contralateral tube damage, previous abdominal surgery, previous PID. So what is the chance of having subsequent intrauterine pregnancy rates? So if we do salpingotomy, the rates of intrauterine pregnancies were 75%. And what were the time? And if we did salpingectomy, then what was the chance of having intrauterine pregnancy? It was 40% in such women. In this information is specific to only the women who have a history of fertility reducing factors. Okay? These are the things that you should keep in your mind. So what is the chance of having persistent trophoblastic tissue after salpingotomy? Your answer is 3.9 to 11%. This question has also been asked in the single best answer format. If you have decided to give pharmacological treatment, then you should know that many different drugs are available, but we prescribe methotrexate because we have more experience of giving methotrexate and the dosage is easy. Even with the methotrexate, you can have like different treatment regimens. So which one your unit is practicing, you can adopt that. But mostly, the most common and the most favored criteria is to give methotrexate at a dose of 50 milligrams per square meter. And then that is the most commonly given, regimen. It's very helpful. That is one thing. Okay? So you should remember that systemic methotrexate, this is the most commonly used drug for the pharmacological treatment of tubal ectopic pregnancy. It can also be given in multiple dose regimen. Methotrexate is most commonly given as a single intramuscular dose of 50 milligrams per square meter. Then serum beta-HCG level should be tested on day 4 and day 7 after administration of the methotrexate. If the beta-HCG level decreases by more than 15% between day 4 and day 7, then beta-HCG levels are measured weekly until less than 15 international units per liter. This is the ideal scenario. That's what we are looking for. But in In those cases, the level of the beta ICG doesn't decrease by 15%. A repeat transvaginal ultrasound, it should be considered to exclude ectopic fetal cardiac activity and the presence of significant hemoperitoneum. And consideration may then be given to administration of a second dose of methotrexate. Another question they can ask you is that what is the overall success rate of methotrexate for tubal ectopic pregnancy? Your answer is 65 to 95%. That is one. Okay. So what is the success rate of the methotrexate treatment in cases of tubal ectopic pregnancy? 65 to 95%. Another question they can ask you is that how many patients will require a second dose of methotrexate? Your answer is 3 to 27%. Yeah. Don't worry, all of these notes you are going to find on the web page also. Okay, don't worry. Yeah, we will write down in the chat box also. Don't worry, because these numbers are important. Okay. So there are different predictors of success of the treatment, like the initial serum beta ICG, like if the treatment has been successful, and then what will happen? Like if the beta ICG levels are less than 1000, then the success rate of the treatment is going to be 81 to 98%. See, because the success rate is dependent on the initial levels of the beta ICG. So the patient you have attended, the first beta ICG level was less than 1000, then there is 81 to 98% chance that the ectopic pregnancy will be treated successfully with methotrexate only. On the other hand, if the patient presented with serum beta ICG levels greater than 5000, then the success rate of the methotrexate, it drops to 38%. See, huge difference. 81 to 98% versus 38%. So when you are deciding about the modality of the treatment, you have to think about the initial presentation serum beta ICG level. The second predictor of success is ultrasound appearance of ectopic pregnancy. The presence of a yolk sac, fetal pole, and or fetal cardiac activity, these are significant predictors of failure of the treatment. Which factors? If you did the initial ultrasound and you have seen a yolk sac, you have seen a fetal pole, and or fetal cardiac activity. So all of these are significant predictors of failure of methotrexate. So what will indicate that your treatment is going to be successful? Obviously, if we don't visualize any gestational sac, and it means that the pregnancy was very early, so the serum beta ICG level will be lower. So what will happen? You will give methotrexate and the patient is going to have like a successful therapy of the ectopic pregnancy. Then the third predictor of success is going to be pre-treatment change in the serum beta ICG level. So you have done the first level, then the second level and the third level, and the level is rising slightly. There are very small increases in the beta ICG levels before administration of the methotrexate, then it means that the treatment is going to be more successful because there is not a lot of beta ICG. So if the level of the beta ICG increases by 11 to 20% over a period of 48 hours before administering methotrexate injection, then it means that the treatment is going to be very successful. How much rise? Just 11 to 20%. Okay, you did the baseline, then you repeated at 48 hours, and now the level has risen by 11 to 20%. So it predicts that the treatment with methotrexate is more likely to be successful. The fourth predictor of success is decrease in beta HCG levels from day 1 to day 4 after methotrexate. So the success rates of 88 to 100% they have been reported if the serum beta HCG level decreases from day 1 to day 4 after administration of the methotrexate, and as compared to the only 42 to 62% if the serum beta HCG level increases. So if the level is decreasing between day 1 to day 4, there are 88 to 100% chances of a successful treatment. While if the levels of the beta HCG are rising between day 1 to day 4, then the chance of success will drop to 42 to 62%. So every pregnancy is unique and they are going to behave in the different ways. So the success rates of the treatment are going to be different, and they are going to be different from patient to patient. So just remember the things because these levels because they are helpful in deciding about the most suitable treatment for your patient. So then, who should be getting the methotrexate? There are certain criteria. Okay? First, you should know that patient, what is the history of the patient, and see that is the patient able to tolerate the side effects of methotrexate therapy. Remember, this is an anticholinergic agent. Folic acid is required for the synthesis of all cells in the mitosis, right? So if there is no folic acid, there can be like abnormal growth of the cells. That is the mechanism of action of the methotrexate. So what are the adverse effects of the treatment? So first of all, we have to tell the woman that when we are giving them methotrexate therapy, during that time they should avoid alcohol and folate containing vitamins like choline, because you know what can happen, they will interfere with the activity of the drug. Tell your patient about the adverse effects of the treatment which you are going to give her. So if you are giving methotrexate, so what are the adverse effects? Bone marrow suppression, pulmonary fibrosis, non-specific pneumonitis, liver cirrhosis, renal failure, and gastric ulceration. And the most common adverse effects, these are the most serious, that's why side effects, that's why we call them adverse effects. And the most common other effects are going to be, which the people are going to experience. These are the flatulence and bloating due to intestinal gas formation. Then there can be transient elevation in liver enzymes and stomatitis. All of these things are common side effects. So if you are giving some treatment, then there should be some contraindications for the treatment also, because everyone is not going to be a suitable candidate to get the methotrexate. So what do you think? What are the contraindications? Yeah, you can always write down in the in the chat box. Okay. No, this is not a contraindication. Okay. Okay. Let's talk about the contraindications. So yeah. Yeah, what do you want to say? Yeah. Yeah. Okay. Yeah. Very nice. Someone wrote hemodynamic instability. Yes. Excellent. Yeah. What else they can have? Yeah. Yes. So hemodynamic instability. That is the first contraindication. Yeah. Yeah. If this was unplanned pregnancy and the woman is breastfeeding, yes, I'll agree with you. Yes. Chronic liver disease. Yeah. Okay, let's go over them. Well done. Keep it up. Because if you are talking back, you're telling me, giving the answers, this is interactive, you're going to retain this information. So the contraindications to methotrexate: hemodynamic instability, presence of an intrauterine pregnancy, if the woman is breastfeeding, if she is unable to comply with follow-up, like she is living in a far-off area, it is hard for her to come back to the hospital, or the patient's behavior is not reliable. like the compliance is questionable because on different accounts, then you have to keep them inside hospital and monitor them. Or if they refuse, then you cannot give them methotrexate. Then if they are known to be sensitive to methotrexate, then chronic liver disease, then if they have pre-existing blood dyscrasias, if they have active pulmonary disease, because methotrexate is going to cause pulmonary fibrosis. Then if they are immunodeficient or they have peptic ulcer disease. So all of these things are important. So and then if we talk about the single dose protocol, then you should know that on day 1, you need to do certain tests. Which tests should be done? Test the serum beta IgG, urea and electrolytes, liver function tests, full blood counts, blood group, and then if all of these things are normal, then you can, normal I mean in the reference range, then you can give 50 milligrams per square meter intramuscular methotrexate. So there is a formula for it which you should be knowing about, and then we calculate the dose of the methotrexate. We are going to take the under root of the height into weight divided by 3500 multiplied by 50. That is the formula, okay? So you have administered the intramuscular methotrexate on the day 1. Then you should repeat the serum beta IgG on day 4 after. So the day you are administering, that is day 1. That is not day 0. Okay, don't confuse them. That is day 1. Then test serum beta IgG on day 4 and then test it again on day 7. So serum beta IgG, if the beta IgG level decreases less than 15% between day 4 to 7, then you need to repeat the TVS and then methotrexate 50 milligrams if still she fulfills the criteria for medical management. Level is not decreasing, it is the increase is less than the anticipated one. So then repeat TVS. I mentioned this point earlier. To repeat TVS and then again, if they still fulfill the criteria for methotrexate, then you are going to give them the second dose. And if the beta IgG decrease greater than 15%, then you are going to repeat the serum beta IgG weekly unless it will become less than 15 international units. So after talking about all of these things, what do you think? What are the indications for giving methotrexate therapy? Yes, any one of you? Yeah, no problem. You can write down in the chat box. Yeah, actually, this is a very lengthy guideline, but all of these areas, all of these points we are discussing here, they are very high yield. Okay, so don't worry about the time. The time you are going to spend here, it is going to pay you off during the exam. So, a good candidate for methotrexate, they will have has the following criteria, has these criteria. Patient will be hemodynamically stable. They will have low serum beta IgG, ideally less than 1500, but the levels can be up to 5000 international units per liter. There should be no fetal cardiac activity seen on ultrasound scan. Then certainty that there is no intrauterine pregnancy. And then the patient also has to consent that she will be coming back for the follow-up. If we cannot offer follow-up, then give the definitive treatment so that there will be no, patient will not be at risk of having some, disrupted ectopic at home. That is a bad idea. And obviously the patient is not sensitive to methotrexate. So here I will mention the NICE criteria also because it also endorses the same criteria. No significant pain, unruptured ectopic pregnancy with a mass smaller than 35 millimeter with no visible heartbeats. Serum beta IgG level between 1500 to 5000 international units per liter. And there is no intrauterine pregnancy. So confirm the diagnosis and then give them the drug and monitor them like I mentioned before. So this is the pharmacological treatment. Remember the limits, less than 1500 international units at initial presentation, so you can give them expectant treatment. If the levels are between 1500 to 5000, then we offer pharmacological treatment. Levels beyond that, you have to assess the condition of the patient and preferably you will go for other treatments. Mind you, we are still talking about the tubal ectopic pregnancy. So the next type of management can be expectant management. So who is suitable for them? So the expectant management, this is a suitable option for the patients, for the patient who have been appropriately selected and counseled. First of all, they should be willing to attend the clinic for follow-up, and they should be able to do that. Willingness is one thing, like they are not living in the periphery, they don't have the resources to come to the hospital, then don't offer them. In the case of emergency, don't offer them, or for like the routine follow-up, don't offer them if they can't come to the hospital. And they have minimum, negligible. Never ignore the pain, any intensity of pain the patient is having, you should take it very seriously. So if they have minimal pain and they have low or declining serum beta IgG levels, then this treatment is going to be successful. And the reported success rates of the expectant treatment, these are 57 to 100%, but depends upon the baseline criteria of the patients also like that. So obviously the success rate depends upon the level of the serum beta IgG. Success rate will be very high if the serum beta IgG levels are low, and success rate will be low if the serum beta IgG levels are high. So you don't have to go into the details. Just remember, this is the basic point, that if the levels of the beta IgG are very high, then the success rate will drop. So that's why we are maintaining a cutoff level of 1500 international units. So you can offer the expectant treatment management if the serum beta IgG levels at initial presentation are less than 1500 international units in cases of tubal ectopic pregnancies like that. Okay, the next type of pregnancy we are going to talk about is the cervical pregnancy. So the surgical, pharmacological, and conservative treatment, they can be offered in cases of cervical pregnancy. Let's go over it. So medical management with methotrexate, it can be considered for cervical pregnancy. Surgical methods of management, these are associated with a high failure rate, and they should be reserved for those women who are suffering life-threatening bleeding. Only in cases of emergency, you should go for surgical treatment. So early accurate diagnosis is the key factor in the conservative management of cervical pregnancies. So if the gestation age is less than 12 weeks and there is no fetal cardiac activity and the serum beta IgG levels are low, then the chance of success is going to be very high. So different methods have been used here, like the dilatation and the curettage, systemic methotrexate, local injection by potassium chloride, or methotrexate. So many different things they have been used. And if the gestational age is less than 9 weeks and beta IgG levels, if the gestational age is more than 9 weeks, or beta IgG levels are more than 10,000, or CR length is greater than 10 millimeter, and the fetal cardiac activity is present. So all of these 4 factors are associated with a very high risk of primary failure of the treatment of the cervical pregnancy with systemic methotrexate. In addition, if we offer them combination therapy in the form of, like you are giving them methotrexate and we are giving intra-amniotic injection. So these two things are going to increase the chances of the successful treatment, like that. Okay. So so you have to decide carefully. Many other treatments they have been suggested, like uterine artery embolization, but this is not recommended by the college, so we will not offer this treatment for the cervical pregnancy. So now the next one, management of cesarean scar pregnancy. So women who have been diagnosed with cesarean scar pregnancy, they should be counseled that such pregnancies, they are associated with severe maternal morbidity and mortality. Very high risk pregnancies. So very high risk cesarean scar ectopic pregnancy. Okay. So medical and the surgical interventions with or without additional hemostatic measures, they should be considered in women with first trimester cesarean scar pregnancy. At the moment, there is insufficient evidence to recommend any one specific intervention over another for the cesarean scar pregnancy, and the current literature supports a surgical treatment over medical treatment. Why? Because the surgical treatment in such scenarios is more cost effective as compared to the methotrexate therapy. Okay, so then if your patient has interstitial ectopic pregnancy, then what options do we have? So the non-surgical management is an acceptable option for stable interstitial pregnancies. Expectant management is only suitable for women with low or significantly falling beta-ICT levels in whom the addition of methotrexate may not improve the outcome. Like why? Because the level of the serum beta-ICT is very low, and just by careful observation we will see that the levels are dropping. That's very good. So in that case, we don't have to give additional therapy in the form of methotrexate treatment, because remember, this drug has significant side effects. So if we use pharmacological approach and we give methotrexate, it is effective, and but still you can ask that should we give it locally or systematically. There is no consensus on it. Okay, so you can give the intramuscular, or that would be better in such cases. There is no specific preference that you should give it locally or you should give it systematically in the form of intramuscular injection. So surgical management you should offer, and again you will do laparoscopic cornual resection, or you can do salpingotomy, and both are effective options. And other approach will be hysteroscopic resection under laparoscopic or ultrasound guidance. And there is at the moment insufficient evidence on safety and complications in future pregnancies as to recommend other non-surgical methods. So only these methods are recommended that give them methotrexate, or you can do the surgery, and during the surgery we can do the laparoscopic resection, or we can do the salpingotomy. Better we should adopt the laparoscopic approach. Okay, that is better, and we can do the resection, and that should be done under ultrasound guidance. Okay, that is one. Just remember the main points in the treatment, because they can ask you in the single best answers, and they can also ask you in the EMQs. Nowadays the trend is that in the EMQs they want to ask you, how do you classify the evidence for the management of this type of pregnancy? So we have just read that for other types there is of the surgery for the interstitial pregnancy, there is insufficient evidence. Okay, so you should do laparoscopic self-injectomy or self-ingotomy. So information is very specific. It's not necessary to read 10 guidelines on the same topic. Okay, just read one guideline, but you should be sure of the information that you have gathered. So we call them learning points. So your learning points should be learned very efficiently. Okay, understand them and repeat them several times. Okay, so how do we manage a carnal pregnancy? So the carnal pregnancies, they should be managed by excision of the rudimentary horn via laparoscopy or laparoscopy. Okay, so like we mentioned before, that it is likely to occur in the unicornuate uterus, and in the unicornuate uterus, if there is rudimentary horn, it should be resected, because otherwise there will be risk of a repeat ectopic pregnancy. So if your patient has ovarian pregnancy, what should be done? So definitive surgical treatment is preferred if laparoscopy is required to make the diagnosis of ovarian ectopic pregnancy. Systemic methotrexate, it can be used to treat ovarian ectopic pregnancy when the risk of surgery is high or postoperatively in the presence of persistent residual trophoblastic or persistently raised beta ICG level. So you will start with the surgery, but if it is persistent, then you will persistent. How you will know that? Because the beta ICG levels will be raised. So in that case, you will have to give them methotrexate. So you need to counsel your patient very seriously, okay, very effectively. Why? Because they should know that they are choosing one type of treatment, but this type of treatment may fail, and then they will have to take another type of therapy also. They will have to accept. So they go over all the options with the patient and then make a diagnosis, okay? Then make a plan for the management of the patient. So what will you do if your patient has an early abdominal pregnancy? Obviously, you should do laparoscopic removal. That is the best option for the treatment of early abdominal pregnancy. Possible alternative treatment methods, they would be systemic methotrexate with ultrasound guided feticide. You cannot give like methotrexate into the abdominal cavity. Under the ultrasound guidance, you have to give it to the fetus. Okay. First, you have to do ultrasound guided feticide. Kill the fetus and then give them methotrexate. In case the pregnancy is advanced, then obviously you will have to do lepton. That is one. Okay. Actually, the pregnancy, it can become implanted on the gut, and the common sites are like the ileus. The placenta may grow on it. Okay. So it can occur on the ileus. It can anchor into the ileus, into the small intestine, large intestine, blood vessels. And then the problem is that when the placenta, it may preserve itself. There can be placental retention and it can cause ileus. Then there can be bowel obstruction, fistula formation, hemorrhage, peritonitis. Okay. And the mortality is lower than when it's removed. If we are trying to remove the placenta in such cases, the patient can have a life-threatening hemorrhage like that. Okay. So then the adjuvant treatment with methotrexate they can be given, and another option will be selective arterial embolization. All of these things they have been described. Okay. So your consultant will have to decide that what they can do to remove the placenta. So now if you have diagnosed the patient to be pregnant with a heterotopic pregnancy, what will you do? Okay. The intrauterine pregnancy, it must be considered in the management plan. Management will base on the intrauterine pregnancy because we need to save that. Methotrexate should only be considered if the intrauterine pregnancy is non-viable. There is no fetal cardiac activity, so then you can give them methotrexate. Or if the woman doesn't want to continue with the intrauterine pregnancy, because patient can have like several ideas. They may be like scared that maybe something bad will happen to the normally located baby and the pregnancy. So they will opt in most of the cases, they will opt for the complete therapy and they will say that better to remove the both pregnancies. Okay. So in that case, you can give methotrexate. So when we have to do the feticide in such cases, what should be done? Local injection of the potassium chloride, or you can give hyperosmolar glucose with aspiration of the sac contents. This is an option for clinically stable women. First give them the injections and then aspirate the gestational sac. Injections to kill the baby. Surgical removal of the ectopic pregnancy is the method of choice for hemodynamically unstable women, and this is also an option for hemodynamically stable women. Which option? Surgical removal of ectopic pregnancy, which is a heterotopic pregnancy, intrauterine and extra. So you can remove the extrauterine pregnancy surgically also. So then expectant management. Can we offer that in cases of heterotopic pregnancy? Yeah. So in the chat box, somebody wrote that we cannot. Why not? Okay. So you have written, yeah, that it is acceptable. So if you are saying that it is acceptable, then you should give a logic also. So what is your idea? All right. Okay. Okay, so expectant management is an option in heterotopic pregnancies where the ultrasound findings are of a non-viable pregnancy. So this is a miscarriage or non-viable pregnancy. So it is going to pass out like that, okay? So that is one thing. So in that case, you can just give them regular follow-ups and then you can see, follow her up and things are fine, then you don't have to offer any intervention. Okay, so we can say that expectant management of an interstitial heterotopic pregnancy is suitable for a woman who has no symptoms at all. Okay, and so that's how you can manage them. A very important patient safety issue here that you should know about the blood group of the woman. Okay, so the question arises, if the woman is Rhd negative with an ectopic pregnancy, does she need anti-D immunoglobulin? Yeah, we should offer anti-D prophylaxis as per the national protocol to all Rhd negative women who have surgical removal of an ectopic pregnancy or where bleeding is repeated, it is heavy, or it is associated with abdominal pain. Okay, so alloimmunization, it has been reported in the following ectopic pregnancy and 25% cases of the ruptured tubal ectopic pregnancies, they are associated with a significant number of the fetal cells in the maternal circulation. That is one thing, okay? So then, so it is recommended. Okay, so the NICE recommends only offering anti-D prophylaxis to those who are undergoing surgical management, but this is contrary to the British Committee for the Standards in Hematology guidance. That is one thing, okay. So the woman who undergoes surgical management of pregnancy, they may be at higher risk of sensitization due to a mixing of the fetal and maternal blood. That is one, okay. So better to give the treatment in such cases. Now your patient who presented with an ectopic pregnancy and you diagnosed her that what type of pregnancy, ectopic pregnancy she has. You counseled her, you did the baseline investigations, you managed the case, and now the question will be what she should expect in the future, what will happen to her fertility, is she going to have another repeat pregnancy? So you need to address all of these issues, okay? So if she doesn't have any history of subfertility or the tubal pathology, then her chance of having another live pregnancy, healthy pregnancy, is going to be the same as for anyone else. What is the chance of having a repeat ectopic pregnancy? you will say that if she is stable and there is no history of infertility or no history of tubal disease, tubal pathology, then her risk of future tubal ectopic pregnancy or tubal patency, it is going to be the same as that in the general population like that. Okay, and the rate of fertility is also going to be the same. Okay, whatever, it is not modified by the type of the treatment she has received. Okay, any type of management, her chances of having a successful normal pregnancy or tubal pregnancy are going to be the same. So the method of treatment is not going to affect the fertility outcome, the future fertility outcomes. Women with a previous history of subfertility, they should be advised that the treatment of their tubal ectopic pregnancy with expectant or medical management is associated with improved reproductive outcomes as compared to the surgery. So if the women are receiving methotrexate for the management of tubal ectopic pregnancy, then you should advise them there is no effect on the ovarian reserve. This is a very legitimate question, very valid question, that what will happen to the ovaries? So nothing will happen to the ovaries, okay? They will continue functioning like they were doing before they developed this ectopic pregnancy. So if the women have undergone uterine artery embolization and systemic methotrexate for non-tubal ectopic pregnancy, we need to tell them that live births have been reported in the subsequent pregnancies. So then the women, if they have undergone laparoscopic management of their ovarian pregnancies, they should also be advised that their chances of their prospects of having a future pregnancy and fertility, they are good. So you have to explain everything to the patient like that. So if your patient has like a history of subfertility, especially those who are over the age of 35, the radical surgery, it has been shown to be associated with lower rates of subsequent intrauterine pregnancy as compared to the conservative or medical management. As you will recall, like after the cesarean section, they can have like relative subfertility for some time, and then they will take some time to become pregnant again like that. That is one thing, okay? So what is the chance of having a repeat ectopic pregnancy? So the patient has received any type of treatment, the chance of having a repeat ectopic pregnancy is reported to be 18.5%. So 18.5%, that is one. And if the patient has like 2 ectopic pregnancies, then of course the chance is going to be much more higher than this one. So you need to keep all of these things in your mind. Roughly, the chance of having another ectopic will be like 1 ectopic pregnancy, then the chance of having the second ectopic pregnancy is 18.5%. And if the patient has 2 ectopic pregnancies, then the chance of having another ectopic pregnancy is going to be between 25 to 30%. And if the patient has 2 ectopic pregnancies before, then the chance of having another ectopic pregnancy is third ectopic pregnancy is going to be 40%. My reference is up to date. Okay, the latest edition of the up to date. That's why I'm telling you. So she has taken treatment of ectopic pregnancy. So what support and counseling should be provided? So you need to tell the patient about advantages as well as disadvantages of the all treatment options of the ectopic pregnancy. And the patient should actively participate in selecting the treatment option for herself. So the patient has autonomy. She should choose. You are just going to give the information and help her in making the decision. We will not dictate her that you need to take up this treatment. Okay. Then the women should be made aware of how to access support via the patient support groups, like what support groups are available, ectopic pregnancy trust, or local bereavement counseling services. So So we can also counsel the women who are taking methotrexate for the treatment of ectopic pregnancy that they should practice muscle relaxation techniques. We can train them. Okay, they will go to the physiotherapist and they can train them because it is going to be helpful for them. Then the women who are treated with methotrexate, they should wait at least 3 months before trying to conceive again because we need 12 weeks to wash out the drug from this drug out of the system of the patient like that. Okay, so they should wait for 3 months and then they can start trying for another pregnancy. So these are the important things. Then in the service and the training, the question is, what is the most appropriate setting for the management of women with an ectopic pregnancy? Okay, so the providers of the early pregnancy care, they should provide a 7-day early pregnancy assessment service with direct access for the women referred by the GPs and the accident and emergency departments. And they should follow the current NHS guidelines. And the available facilities for the management of the suspected ectopic pregnancy should include diagnostic and therapeutic algorithms, TVS, and beta-HCG estimations. And women should have access to all appropriate management options for their ectopic pregnancy. And if local facilities they do not provide all options, then clear referral pathways they should exist to allow them to access appropriate care. So these are the things and the training implications, like the resident at the level of the ST5, you should know that how you should diagnose ectopic pregnancy, and you should be able to do all of the procedures like laparoscopy, laparotomy, and you should be able to diagnose on the ultrasound. And then again, you should be able to undertake medical management through via ultrasound guided needle techniques, and they should have received training before offering this to the patients. And if the clinicians they decide to do the surgical management and of the ectopic pregnancy, and then if you cannot carry out the full range of the treatment, then you should seek support. Someone should be covering you. Okay, if you have done supervised training, then you should be offering all of these services and the surgical procedures for the patients. Yeah, any questions, anything? Just a moment, please.
This conference will now be recorded.
Okay, yeah, I was going over your questions. So in the exam, the most commonly these questions are asked. The definition of ectopic pregnancy, you should be able to identify that implantation of fertilized ovum to any location other than the endometrial cavity. Okay, fertilized ovum. Don't say embryo or this thing because the pregnancy is there. What is the incidence of ectopic pregnancy in all pregnancy? Your answer is 2% of the all pregnancies. Okay, and ectopic pregnancy is responsible for 5% of all maternal deaths. That is very important. Okay, what are the risk factors for an ectopic pregnancy? Maternal age of more than 35, previous history of ectopic, previous tubal abdominal pelvic surgery, PID, smoking, endometriosis, infertility, and assisted reproductive techniques. Contraception failure, most commonly if the intrauterine copper device was intrauterine device, could be Mirena, could be copper T, anything can be there. Okay. Most common clinical presentation you already know: first trimester bleeding, pain, sharp or stabbing pain, hemorrhagic shock can be there. Okay, which anatomical locations are most likely to have ectopic pregnancy? Tubal. 99.4 pregnancies will be in the tube, can be in the interstitial region like 1%, ischemic portion 25%, and the ampulla will have 55% of the ectopic pregnancy. In the uterus, they can be in the rudimentary horn, in the cervical region, and the Caesarean scar pregnancy They can also be in the intraligamentous region. They can be in the ovaries, or they can be abdominal like that. Okay. So then they can give you the signs, and then you will have to diagnose it. Then they can ask you that what are the treatment diagnostic methods you can use. So we have just talked about them like that. Okay. So how often do we monitor the serum beta HCG levels? You should remember that in the NICE guideline, this says that if the levels are rising by less than 63% every 2 days, then it will point towards the ectopic like that. Okay. So at the beta HCG levels exceeding 3,500, if you don't see any intrauterine gestational sac on the TVS, then you're going to diagnose an ectopic pregnancy. Or otherwise, if you see it outside the uterus, then you can diagnose it. So progesterone monitoring. So remember that if the levels of the progesterone are less than 5 nanograms per ml, they mark abnormal pregnancy. And if the levels of the serum progesterone are more than 25 nanogram, they will point towards a successful pregnancy. Okay. So the findings I have already told you, and pseudosac, you should know that there will be like the decidual endometrium and a small amount of the intrauterine fluid, which will make intrauterine, which is the intrauterine fluid. So it will give the appearance of a pseudosac like that. Levels are important when you should expect to see the gestational sac on the transabdominal ultrasound if the beta HCG level is more than 6,000 international units. So then the TVS at you can see the gestational sac at levels more than 1,500 international units like that. Okay, these are the things. And then the differential diagnosis, because the patient can have many other pathologies which can present in the same way. Keep these things in the differential diagnosis: normal pregnancy, ruptured ovarian cyst, bleeding corpus luteum, spontaneous miscarriage, salpingitis, appendicitis, adnexal torsion, and endometriosis like that. Okay. So if the patient has IUD, how do you diagnose? Obviously, the patient will have pain, but the diagnosis will obviously be more difficult if the patient already has this IUD in place. Okay, and the beta HCG level should be checked like that. So the treatment modalities, we have just talked about them. You should be able to remember this information, okay, because these are very important for you. Then they like to ask you about the contraindications to the methotrexate, and then they can ask you that how methotrexate treatment is monitored in ectopic pregnancy. So you know that we will give on day 1, and before day 0, you should have the level. Okay. Day 0, day 4, day 7. These levels are important for you like that. Okay. So contraindications of laparoscopy in the surgical management of the ectopic pregnancy. Obviously, if the patient is in shock and you can see like you anticipate more than 2 liters of peritoneum, and there is uncontrollable massive bleeding, here the speed will work. So you will have to go for a laparotomy. So these are the things. And okay, how you will know that this is just an ectopic pregnancy and mild pain, or this is like ruptured ectopic? So remember, in the ruptured ectopic pregnancy, your patient will have pleural pain and also abdominal pain, and patient will describe a feeling of weakness, dizziness, and fainting. So it means that why fainting? Because of extreme pain and the vagal stimulation. That is important. So that's all I have to tell you about the diagnosis and management of ectopic pregnancy. So if you are listening to this video, in this podcast, please go over it. And this is a very important guideline, and you should expect to get several questions, at least 6-7 questions on the same topic. It's worth reading. Remember them, and the algorithms and the text you can find on the guide on the website. And if you are here, then remember you need to do the questions, because on the weekend most likely we are going to have the test like that. This test is not going to do any good to me, but the point is that uh, you should do these questions and the stuff because it is important for you, and in the exam they are going to ask you many things from here. So have a great rest of the day, and let's meet tomorrow with the next topic. If you have any questions, please feel free to post in the groups, and I'll do my best to answer them at the earliest. Thank you very much. This is Dr. Aisha. If you want to contact me on WhatsApp, you know my number. It is +44 758 730 2192. Or you can drop an email at arismrcog@gmail.com. Thank you very much. See you. Bye bye.